to mudaliar and menon clinical obstetric lecture series. So the topic that we'll be covering in this lecture is going to be abortion. So abortion is a very important question, okay, very favorite question in exams. So yeah, please pay attention. So first let's look at the definition of abortion. So how do we define abortion? So it is the spontaneous miscarriage, okay, a spontaneous miscarriage or abortion. Spontaneous miscarriage is defined as the spontaneous termination of pregnancy before 20 weeks of gestation. So what is abortion? It is the spontaneous miscarriage is defined as the spontaneous termination of pregnancy before 20 weeks of gestation. The WHO defines, what is the WHO definition? The WHO defines miscarriage as a spontaneous. So the WHO miscarriage definition defines miscarriage as a spontaneous expulsion of the conceptus, spontaneous expulsion of the conceptus weighing 500 grams or less. So what is the WHO definition? It is the spontaneous expulsion of conceptus weighing 500 gram or less. Incidence is 10 to 15%. Now, how are we going to classify abortion? So, abortion can be mainly two types. Either a spontaneous abortion, which is occurring sporadically or recurrently, whereas induced means we are induced by externally. Spontaneous abortion, the first type is a threatened miscarriage. A threatened abortion or a threatened miscarriage. The second one is inevitable miscarriage. Inevitable abortion or inevitable miscarriage. Complete miscarriage or incomplete miscarriage. Missed miscarriage or a septic abortion. So classification is going to be threatened miscarriage, inevitable miscarriage, complete miscarriage, incomplete miscarriage, or a missed miscarriage or septic abortion. Threatened, inevitable, complete, incomplete, missed or a septic abortion. Whereas induced abortion can be either a legal one, that is done by MTP, medical termination of pregnancy, or it can be an illegal one. Legal or illegal. Illegal is nothing but criminal abortion. So this is the classification of abortion. Now let's move on to the etiology. So why does abortion occur? So abortion occurs mainly due to, we can classify them as fetal factors and maternal factors. So what are the fetal factors? Fetal factors mainly are any kind of chromosomal aberrations. So mainly the fetal factors are any chromosomal aberrations. Then moving on to maternal factors. Under maternal factors, we have infection, we have systemic disease, we have autoimmune disorders and uterine causes. So infections, systemic disease, autoimmune disorders and uterine causes. So what are the infections causing abortion? Pneumonia, malaria, acute appendicitis and pyelonephritis, as well as viral infections. So viral infections are very common. Then pneumonia, malaria, acute appendicitis and pyelonephritis. Next, moving on to systemic disease. So under systemic disease, we can classify them as diabetes, renal disease, chronic hypertension. Okay. So under infection we have pneumonia, malaria, acute appendicitis, pyelonephritis and viral infections. In systemic disease we have diabetes, renal disease, chronic hypertension. All these are systemic diseases. Diabetes, renal disease, chronic hypertension. And next, moving on to autoimmune disorders. Under autoimmune disorders, we have APLA. APLA means what? Antiphospholipid antibody syndrome. SLE, systemic lupus erythematosus, as well as inherited thrombophilia. Under uterine causes, we have congenital malformation of the uterus. Any congenital malformation of the uterus, cervical incompetence, submucous fibroid, Asherman syndrome. Asherman syndrome where there are uterine adhesions. All these causes are very important. So again, I'm going to revise the causes for you. So etiology, you have fetal factors. In fetal factors, we have mainly the chromosomal aberrations. And in maternal factors, we have infections, we have systemic disease, we have autoimmune disorder and uterine causes. Infections, you have viral infection, pneumonia, malaria, acute appendicitis and pyelonephritis. Systemic disease, you have diabetes, renal disease, hypertension, chronic hypertension. Under autoimmune disorders, you have APLA. APLA is what? Antiphospholipid syndrome, SLE and inherited thrombophilia. Uterine causes, you have any congenital malformation of the uterus, cervical incompetence, submucous fibroid as well as Asherman syndrome. Okay, apart from these causes that we have learnt, so in maternal factors we also have endocrine causes, maternal habits, exposure to toxic agents as well as trauma. So what are the endocrine causes causing or leading to abortion? So the first is related to thyroid. So thyroid, the cause may be hypothyroidism or hyperthyroidism. Next is progesterone deficiency. Very important, progesterone deficiency and luteal phase defects. Under maternal habits, we have smoking, excessive alcohol consumption. So endocrine causes are hypothyroidism, hyperthyroidism, progesterone deficiency and luteal phase defects. In maternal habits, we have smoking, excessive alcohol consumption. So exposure to toxic agents. So what are the exposure? So exposure to toxic agents such as anesthetic gases, radiation may result in miscarriage. Trauma especially these two are very important. In these two procedures, trauma is very common leading to abortion, amniocentesis and chorion villus sampling. So what are the endocrine causes? Maternal habits, exposure to toxic agents and like anesthetic gases and radiation, and trauma, amniocentesis and chorionic villus sampling. So I am going to revise the maternal factors alone. So we have infections, we have systemic disease, we have autoimmune disorder, we have uterine causes, we have endocrine causes, we have maternal habits as well as exposure to toxic agents and trauma. In trauma, we have amniocentesis and chorionic villus sampling, exposure to toxic agents like anesthetic gases and radiation, maternal habits like smoking and chronic alcoholism or excessive alcohol consumption, endocrine causes like anything related to thyroid, progesterone deficiency and luteal phase defects. Uterine causes, we know, congenital malformation, cervical incompetence, submucous fibroid and Asherman syndrome. Autoimmune disorders like APLA, SLE and inherited thrombophilia. Systemic disease like diabetes, renal disease, chronic hypertension and infections. So let's look at the signs and symptoms we are going to look in abortion. So in abortion, the primary symptom is going to be amenorrhea and abdominal pain due to uterine contractions. So amenorrhea, abdominal pain due to uterine contractions. Bleeding per vagina due to separation of ovum. Yeah, so bleeding PV due to separation of ovum. And dilatation of the cervix. Very important, dilatation of the cervix due to uterine contractions. And partial or total expulsion of the products of conception. So either partial or total expulsion of the products of conception. So what are the signs and symptoms we see in what are the signs and symptoms we see in abortion? Amenorrhea, abdominal pain due to uterine contractions, bleeding PV due to separation of the ovum, and dilatation of the cervix due to uterine contractions, partial or total expulsion of the products of conception. Amenorrhea, abdominal pain, bleeding PV, dilatation of cervix, and partial or a total expulsion of the products of conception. So, in this figure, we can look at the types of spontaneous abortion. So, if you see this one, okay, this is a threatened abortion, okay. In this figure, this is showing a inevitable abortion, threatened abortion, inevitable abortion, and this is an incomplete abortion, and this is a complete abortion, whereas this one is a missed abortion. So this is a table showing you the types as well as the definitions respectively. Now first is early abortion. So what do you mean by early abortion? Any abortion that is before 12 weeks of gestation is known as early abortion. Then what is late? Late means abortion between 12 and 20 weeks of gestation. Abortion between 12 and 20 weeks of gestation is late. And then the third is spontaneous. Spontaneous is the definition is non-induced abortion. A spontaneous abortion is a non-induced abortion. Then what is an induced abortion? Induced abortion means the termination of pregnancy for medical or elective reasons. Induced abortion means termination of pregnancy for either medical or elective reasons. And then you have therapeutic abortion. Therapeutic abortion, you have termination of pregnancy because of threat to woman's life or health, or because the fetus is dead or has malformations incompatible with life. That is therapeutic abortion. Threatened abortion means vaginal bleeding before 20 weeks of gestation without cervical dilatation and indicating the spontaneous abortion may occur. Next one, inevitable abortion. That is also vaginal bleeding or rupture of the membranes accompanied by dilatation of cervix. Then you have incomplete abortion, expulsion of only some of the products of conception. And then complete abortion is expulsion of all the products of conception. Then you have recurrent or habitual. Recurrent or habitual is 3 consecutive spontaneous abortions. So what do you mean by recurrent or habitual? Recurrent or habitual means there are 3 consecutive spontaneous abortions. Then you have missed one. Detected death of an embryo or a fetus that is not expelled and that causes no bleeding. It's also known as a blighted ovum or an embryonic pregnancy or intrauterine demise. And the last one, you have a septic abortion, where there is a serious infection of the uterine contents during and shortly before or after an abortion. So coming to the first one, very important, what is threatened abortion? So as I already told you, threatened abortion, the definition is threatened miscarriage is one where there is a vaginal bleeding before 20 weeks. So there is vaginal bleeding before 20 weeks. Vaginal bleeding before 20 weeks of gestation with a viable fetus. Okay, so vaginal bleeding less than 20 weeks with a 20 weeks of gestation with a viable fetus, uterine size corresponding to the period of gestation and without cervical dilatation. So the uterine size is corresponding to the period of gestation and it is without cervical dilatation. Without cervical dilatation, that is threatened abortion. So threatened abortion is where any miscarriage, okay, where there is going to be vaginal bleeding less than 20 weeks of gestation and the uterine size is going to be corresponding to the period of gestation without cervical dilatation is threatened abortion. So moving on to the clinical features, first is the symptoms. So the patient is going to get a slight colicky pain in the lower abdomen or a backache. So slight colicky pain in the lower abdomen or backache. Next is slight vaginal bleeding, very slight vaginal bleeding. Sometimes frequency of micturition is going to be there. Now moving on to the signs. So the signs in a threatened abortion, there is no anemia and no pallor. So no anemia, no pallor. If you look at the general condition, there is no hypotension, mild or no tachycardia. So generally there is going to be no hypotension. No hypotension is going to be there. Mild or no tachycardia is going to be there. So what are the signs? No pallor and no hypotension, no tachycardia. On clinical examination, the uterus size corresponds to the period of amenorrhea. So on clinical examination, the uterus size is going to be corresponding to the period of amenorrhea. Okay, the uterus size corresponds to the period of amenorrhea. And the cervical os is going to be closed with slight bleeding through the os. So on clinical examination, the uterus size is going to corresponding to the period of amenorrhea, and the cervical os is going to be closed with slight bleeding through the os. So uterus size corresponding to the period of amenorrhea and cervical os is going to be closed with slight bleeding through the os. On a gentle bimanual pelvic examination which they are doing here, this figure shows a bimanual pelvic examination. The cervix will be soft. So the cervix will be soft and the size of the uterus will correspond to the period of amenorrhea. So this is the classical sign. So there are no much general signs or pallor, but on clinical examination you just need to remember this point. The uterus size will be corresponding to the period of amenorrhea and the cervical os will be closed with a slight bleeding through the os. Moving on to the management of threatened abortion. So how are we going to manage a case of threatened abortion? The first ever management step is reassurance. You need to reassure the patient about this. And next is bed rest. A proper bed rest should be given. Then a repeat ultrasound after a week. So after a week, you will have to repeat an ultrasound. And it is advisable to place these patients in the high risk category. Okay. So it is advisable to place these patients in high risk category as well as monitor them for all these complications during the antenatal period. Remember, all Rh negative pregnant women should be given anti-D immunoglobulin in a dose of, what is the dose of anti-D immunoglobulin? 50 mcg for pregnancies less than 12 weeks. 50 mcg for pregnancies that are less than 12 weeks and 300 mcg for pregnancy more than 13 weeks. So for more than 13 weeks is going to be literally literally 6 times, right? So that is 300 mcg. So less than 12 week means how much anti-D immunoglobulin should you give? 50 mcg. For more than 13 weeks, 300 mcg. Now, confirmation of diagnosis. So how are you going to confirm this? Confirm of the diagnosis. So we are going to confirm the diagnosis by using an ultrasound examination. So a viable pregnancy, indicating any viable pregnancy, that is indicating that the amount of bleeding has not affected the fetus. That is when you are going to diagnose a threatened abortion. So a viable pregnancy indicating that the amount of bleeding has not affected the fetus is the diagnosis. So I'm revising you the management of threatened abortion. The first ever thing is you need to reassure and give bed rest, and you're going to place them in a high risk category. And if it is a RH negative pregnant lady, then less than 12 weeks you're going to give 50 mcg of anti-D immunoglobulin. More than 13 weeks you're going to give 300 mcg of anti-D immunoglobulin. And ultrasound examination, a viable pregnancy indicating that the amount of bleeding has not affected the fetus. Next, moving on to the second type of abortion. Inevitable and incomplete abortion. Okay, so inevitable and an incomplete abortion. So the definition is, an abortion is called as inevitable abortion when the products of conception have not been expelled. So when do you say an abortion is inevitable? When the products of conception has not at all expelled, that is when you call it as an inevitable abortion. Whereas when the products of conception are partially expelled and partially retained, it is known as incomplete abortion. So what are the clinical features, the symptoms? First is history of amenorrhea. Then lower abdominal pain, that is going to be moderate to severe. Then bleeding from the vagina, which is usually heavy. So bleeding from the vagina is usually a heavy one. Then you are going to suspect for an inevitable abortion. And history of expulsion of products of conception. This is for history of expulsion of products for conception is for incomplete and complete abortion. So incomplete abortion. So what are the symptoms? History of amenorrhea for inevitable and incomplete abortion. History of amenorrhea, lower abdominal pain, bleeding from the vagina, generally usually heavy, and history of expulsion of products of conception. So what are the signs? So the signs are tachycardia and hypotension. On abdominal palpation, so on palpating the abdomen, the uterine size, okay, if you look at the uterine size, may correspond to inevitable abortion. Okay, so on palpation, the uterine size may actually correspond to inevitable abortion, or maybe lesser, okay, lesser than the incomplete abortion, lesser than the period of amenorrhea. So in a case of inevitable abortion, the abdominal, the uterine size is going to be corresponding to the period of amenorrhea. But in an incomplete abortion, the uterine size is going to be lesser than the period of amenorrhea. Next, on vaginal examination. On vaginal examination, the cervical os is going to be dilated, and so on vaginal examination, the cervical os is going to be dilated, and the period of the products of conception may be felt in the uterine cavity or the cervical canal in cases of an inevitable abortion. So on vaginal examination, the cervical os is dilated, and the products of conception may be felt in the uterine cavity or the cervical canal in cases of inevitable abortion. Now in case of incomplete abortion, the products of conception may be protruding through the cervical canal in the process of expulsion. So in an incomplete abortion, here the process of expulsion is going to be occurring, because of which the products of conception are going to be protruding through the cervical canal. Next, moving on to ultrasound. So in an ultrasound, what is going to happen? So in ultrasound determines whether the products of conception have been expelled fully or retained within the uterine cavity. So an ultrasound determines whether the products of conception have been expelled fully. Okay, so an ultrasound determines whether the products of conception has been expelled fully or retained within the uterine cavity. So in an ultrasound, it determines whether the products of conception have been expelled fully. Okay, it has expelled fully or retained within the uterine cavity, or in the process of being expelled, So ultrasound determines whether the products of conception have been expelled fully or it has been retained within the uterine cavity or in the process of being expelled. So ultrasound is mainly going to be determining the products of conception, whether it is expelled fully or retained within the uterine cavity or in the process of being expelled. And no fetal cardiac activity is going to be seen, will be inevitable and okay. So very important, in case of inevitable and incomplete abortion, there is no fetal cardiac activity. So in inevitable or incomplete miscarriage, no fetal cardiac activity will be seen in ultrasound. How am I going to manage inevitable or incomplete abortion? So most often the patient expels the products of conception by herself. So most oftenly the patient expels the products of conception by herself. So we need to start IV line with ringer lactate or normal saline, arrange for blood, give a single dose of parenteral antibiotic after the test is done. So after the test is done, we need to give a single dose of parenteral antibiotic as well. And we need to inject tetanus toxoid. So inject tetanus toxoid. Inevitable abortion with pregnancy less than 12 weeks. What does it suggest? So inevitable abortion with pregnancy less than 12 weeks, what you need to do is you need to go for suction evacuation. So in an inevitable abortion with pregnancy less than 12 weeks, then we can go for suction evacuation. So if the uterine size is more than 12 weeks, then oxytocin infusion is going to be given. And incomplete abortion, tablet misoprostol. So under an incomplete abortion, the tablet misoprostol, that is 400 to 600 mcg orally or vaginally is given. And this tablet misoprostol 400 to 600 mcg orally or vaginally will be hastening the process of expulsion. Okay, it will make the process of expulsion at a faster rate. Adequate pain relief, and measures to prevent vomiting should be there. If the patient is hemodynamically unstable, immediate suction evacuation is going to be carried out. So management, I am revising the management. Most oftenly the patient itself will be expelling the products of conception. You need to start an IV line of normal saline or ringer lactate. You need to arrange for blood. You need to give a single dose of parenteral antibiotic after the test is done. Then injection of tetanus toxoid. And inevitable abortion with pregnancy say less than 12 weeks, then suction evacuation should be done. Whereas if the uterine size is going to be more than 12 weeks, then oxytocin infusion is done. Incomplete abortion, you need to give tablet misoprostol around 400 to 600 mcg orally or vaginally, which hastens the process of expulsion. Adequate pain relief must be given and measures to prevent vomiting. Adequate pain relief and measures to prevent vomiting must be done. If the patient is going to be hemodynamically unstable, immediate suction evacuation is carried out. Now, evaluation of uterus when the cervix is sufficiently dilated. Now, if the products of conception are going to be protruding out of the external os, they can be removed by gently introducing a sponge holding forceps. And then we have a manual vacuum aspiration, MVA, manual vacuum aspiration. And the next one, another method is going to be dilatation and curettage or suction evacuation. Now next is going to be post-evaluation care. Post-evaluation care, what you should do in evacuation. Under post-evacuation care, after doing evacuation, what care you should do is you need to continue the oral antibiotics along with analgesics. So after evacuation, you need to continue with oral antibiotics and with analgesics. The woman can be given oral fluids. Okay, the woman can be given oral fluids after 2 hours. So after 2 hours, the woman can be given oral fluids, following which soft solids can be given after 6 hours. So after 2 hours, the woman will be given oral fluids. Following 6 hours, soft solids will be given. She should be counseled regarding family planning methods and advised to plan a pregnancy after 3 months only. So, planning of pregnancy should be done only after 3 months. And anti-D is going to be given whenever indicated. So, what and all we will be giving in post-evacuation care? Oral antibiotics with analgesics. After 2 hours, oral fluids. After 6 hours, soft solids. And family planning methods, and she should plan a pregnancy only after 3 months. Anti-D whenever indicated must be given. Next, moving on to complete abortion. So what is the definition of complete abortion? Complete abortion is said to have occurred when the entire ovum or products of conception has been expelled. So complete abortion is when the entire ovum or the entire products of conception has been expelled. Now, what are the clinical features? First, symptoms. History of amenorrhea. Abdominal pain, abdominal pain and vaginal bleeding with passage of some products or big clots. So, history of amenorrhea, abdominal pain as well as vaginal bleeding with passage of some products or big clots. After passage of products, abdominal pain and bleeding is going to be minimal or none. So what are the symptoms? History of amenorrhea, abdominal pain and vaginal bleeding with passage of some clots. After passage of the products, abdominal pain and bleeding will become minimal. Now what are the signs of complete abortion? So complete abortion signs are general condition is going to be usually stable. So generally the condition is going to be usually stable. On abdominal palpation, the uterine size is going to be less than the size expected for the period of gestation or is not palpable. So on abdominal palpation, on palpating the abdomen, on abdominal palpation, the uterine size is going to be less than the size that is expected for the period of gestation or it is sometimes not palpable. Next, on vaginal examination, the cervical os is going to be closed, and the uterus is going to be smaller than the period of gestation and there is no significant bleeding. An ultrasound examination will confirm the diagnosis of complete abortion. So on complete abortion, what are the signs? General conditions are stable. On abdominal palpation, the uterine size is going to be less than the expected period of gestation. On vaginal examination, the cervical os will be closed. There is no significant bleeding. Next, moving on to missed abortion. So missed abortion, first let's look at the definition of missed abortion. In this condition, the symptoms of abortion appear, the symptoms of abortion appear and subsequently subside. Symptoms of abortion appear and subsequently subside without any products of conception being expelled. So in a missed abortion, there will be symptoms of abortion. They will come and they will subside, but there will not be any kind of expulsion of products. Symptoms of abortion appear and subsequently subside without any products of conception being expelled. The ovum here dies, but is going to be retained in the uterus. So the ovum here actually dies, but is going to be retained in the uterus. So what are the clinical features that we can see in missed abortion? First is the symptoms. In a woman who had amenorrhea and the pregnancy symptoms earlier, the symptoms gradually disappear. So in a woman who had amenorrhea as well as the pregnancy symptoms earlier, the symptoms gradually going to disappear. The symptoms will gradually disappear, especially in a woman who are having amenorrhea and pregnancy symptoms earlier. The symptoms will gradually disappear, and there is going to be brownish discharge may be present. Okay, a brownish discharge may be present. Next, moving on to signs of missed abortion. So we have the uterus does not enlarge anymore and becomes smaller. So the uterus does not enlarge anymore and becomes smaller. On vaginal examination, the bleeding will be minimal or none, and the uterine size is going to be smaller than the gestation. Now let's look at the minimal criteria for diagnosing miscarriage. So what is the minimal criteria for diagnosing a miscarriage? Very important, guys. You should know all these points. First is the crown rump length of at least 7 mm and no heartbeat must be there. So the minimal criteria to diagnose a miscarriage or abortion is, first, the crown rump length should be at least 7 mm and there must be no heartbeat. Okay, no heartbeat should be there. Next, the mean gestational sac diameter of at least 25 mm and no embryo must be there. Mean gestational sac diameter of at least 25 mm and no embryo. Mean gestational sac diameter is going to be of at least how much? 25 mm. Okay, and there is no embryo. Now absence of embryo, absence. So absence of embryo with a heartbeat. Absence of embryo with a heart. At least 2 weeks. Absence of embryo with heartbeat at least 2 weeks after an ultrasound that showed a gestational sac without a yolk sac. You need to diagnose a miscarriage. So what is the second criteria? Mean gestational sac diameter should be of at least 25 mm and no embryo must be there. Then absence of embryo with heartbeat at least 2 weeks after an ultrasound scan that showed a gestational sac without a yolk sac. And the fourth criteria is absence of embryo with a heartbeat of at least 11 days after an ultrasound scan. Of at least 11 days after an ultrasound scan that showed a gestational sac with a yolk sac. So what is the minimal criteria for diagnosing miscarriage? Crown rump length more than 7 mm and there must be no heartbeat. Mean gestational sac diameter should be of at least 25 mm and no embryo. Absence of embryo with heartbeat at least 2 weeks after an ultrasound scan that showed a gestational sac without a yolk sac. Absence of embryo with a heartbeat at least 11 days. Okay, absence of embryo with a heartbeat of at least 11 days after an ultrasound that showed a gestational sac with a yolk sac. Now moving on to the management. So management, first, an ultrasound examination will confirm the non-viability of the fetus. Second, spontaneous expulsion must be there. Third, at less than 10 weeks, okay, evacuation can be done by using medical methods of abortion. Okay, what is MMA? MMA stands for medical methods of abortion. And misoprostol tablets around 600 to 800 microgram Misoprostol tablets, that is 600 to 800 microgram, is going to be inserted vaginally and is very effective. So misoprostol tablets 600 to 800 microgram are inserted vaginally and are very effective. Manual vacuum aspiration, MVA, manual vacuum aspiration or suction evacuation can be done, and anti-D should be given whenever indicated. Now, what are the complications following miscarriage? So, the complications following miscarriage and their respective management is, the first complication of abortion or miscarriage is cervical incompetence. So, what is cervical incompetence and how should we manage cervical incompetence? So, the definition of cervical incompetence is defined as the inability of the uterine cervix to retain a pregnancy in the second trimester and in the absence of uterine contractions. Very important, cervical incompetence is defined as the inability of the uterine cervix to retain a pregnancy in the second trimester. Remember, second trimester. Okay, in the absence of uterine contractions. Now, painless cervical dilatation occurs in the second trimester. So, a painless cervical dilatation occurs in the second trimester with membranes that are bulging through the cervical canal. Followed by expulsion of an immature fetus. So, painless cervical dilatation occurs in the second trimester with membranes going to be bulging through the cervical canal, followed by expulsion of an immature fetus. Now, moving on to the etiology. So, etiology, the cervical incompetence is going to be due to the lack of sphincteric action of the internal cervical os. So, why does cervical incompetence occur? Cervical incompetence is generally due to the lack of sphincteric action. Okay, the sphincteric action will be lost. Cervical incompetence is where there is going to be lack of the sphincteric action of the internal cervical os. So, there is going to be lack of the sphincteric action of the internal cervical os. That is the etiology for cervical incompetence. Lack of sphincteric action of the internal cervical os. So, if you look at the clinical features of cervical incompetence, there is a painless expulsion of the fetus, and fetus is going to be expelled along with the intact membranes. No uterine contraction as well as no pain. There may be premature rupture of membranes. Most often the fetus is going to be born alive. So, how are we going to do the diagnosis? So, during pregnancy, transvaginal ultrasound is going to help you in the diagnosis. So, in transvaginal ultrasound, a cervical length of less than 25 millimeter is suggestive of incompetence. Very important, guys. So, this is a characteristic feature of diagnosing cervical incompetence. So, during pregnancy, in transvaginal ultrasound, if you look at a cervical length, okay, if the cervical length is less than 25 millimeter, it is suggestive of incompetence. The second diagnostic feature is funneling of the membranes. See, funneling of the membranes will be seen in cervical incompetence. And in those with a previous history of cervical incompetence, weekly ultrasounds are going to be done between weeks 16 to 24 weeks. So, between 16 and 24 weeks, weekly ultrasounds must be done. So, during pregnancy, transvaginal ultrasound means it will be showing a cervical length of less than 25 millimeter, which is suggestive of incompetence. Funneling of membranes will be there, and in those with a previous history of cervical incompetence, between 16 to 24 weeks, weekly ultrasounds should be taken. Now, in a non-pregnant state, a detailed history will be collected. Screening for diabetes and serological tests karyotyping of the parents should be done, and autoimmune disorder in the woman may need to be ruled out in repeated abortion. Okay, now how are we going to diagnose a cervical incompetence in a non-pregnant state? So, the diagnostic methods that are described to diagnose cervical incompetence in non-pregnant state is, first is we are going to do a hysterography. Hysterography, especially in the premenstrual phase. Okay, hysterography in the premenstrual phase to demonstrate funneling and widening of the internal os. As I already told you, funneling is a feature of cervical incompetence. So we are going to do hysterography in the premenstrual phase to demonstrate the funneling as well as widening of the internal os. The next one is easy passage. Okay, easy passage of number 8 and number 10. Higgins dilator in the premenstrual phase is also a diagnostic method. So if you are taking number 10 and number 8 Higgins dilator, so this Higgins dilator will be very easily passed. Okay, there is going to be a easy passage of this Higgins dilator in the premenstrual phase. And the third is easy pulling of Foley catheter with an inflated balloon. Okay, so easy pulling of the Foley's catheter with an inflated balloon through the cervical os is another diagnostic method. Hysterography, easy passage of Higgins dilator, and easy pulling of Foley's catheter with an inflated balloon. These are the three diagnostic methods in case of diagnosing cervical incompetence in a non-pregnant state. So coming to the management of cervical dilatation, the treatment of this condition is going to be surgical and consists of reinforcing the weak cervix with a suture. So what we are going to do is we are going to reinforce the weak cervix with a suture, and the suture is going to be generally placed after 14 weeks. Okay, generally after 14 weeks of gestation, but not later than 24. So ultrasound was done to confirm the fetal viability and to exclude congenital malformations. Any obvious cervical infection should be definitely treated before surgery. Now if you look at these two diagrammatic representation obtained on hysterography, okay, or in the figure A, you can see a normally competent cervix. Okay, this is the hysterosalpingography picture of a normally competent cervix. Whereas in figure B, you can see a incompetent cervix. In incompetent cervix, just what you can see here is the funneling. Classic funneling is seen here. Funneling in a incompetent cervix. This is the picture in hysterography. Now let's look at what is cerclage and the cerclage procedures. Very, very important. Cervical cerclage procedures, mainly there are two kind of sutures. One is the McDonald suture. So what do you mean by McDonald suture? McDonald suture is simple. A number 2 monofilament suture. So in McDonald suture, a number 2 monofilament suture is going to be placed in the body of the cervix near the level of the internal os. The suture is placed as a purse string. Okay, the suture is placed as a purse string so as to encircle the internal os, and the suture is going to be tightened around the cervical os. Whereas if you look at the next method, Shirodkar stitch. Shirodkar stitch is more complicated and is not frequently used. Okay, Shirodkar stitch is very complicated, not usually used. The most common method in cerclage procedure is McDonald suture. So what are we going to do in McDonald suture? We are going to take a number 2 monofilament suture and we are going to place it in the body of the cervix near the level of internal os, and we are going to suture it like encircling the internal os. What are the complications of cerclage? So rupture of membranous chorioamnionitis. Okay, rupture of membranes can occur. Okay, chorioamnionitis can occur. Intrauterine infections can occur. So the complications are rupture of membrane, chorioamnionitis and intrauterine infections. Now the success rates are In 80 to 90% of cases, success has been reported with the application of suture. Now, recurrent abortion. Moving on to the next type, that is recurrent abortion. So, what is the definition of recurrent abortion? So, recurrent miscarriage is going to be described as 3 or more consecutive pregnancy losses at 20 weeks or less, or fetal weights less than 500 grams. Very important definition. When do you say it's a recurrent abortion? Recurrent abortion is described as 3 or more consecutive pregnancy losses. 3 or more consecutive pregnancy losses at 20 weeks or less. 3 or more consecutive pregnancy losses at 20 weeks or less, or fetal weights less than 500 grams, or fetal weights less than 500 grams. So recurrent abortion is described as 3 or more consecutive pregnancy losses at 20 weeks or less, or fetal weights less than 500 grams. So what is the etiology of recurrent abortion? So etiology is, first is parental chromosomal abnormalities. Okay, so remember in the definition it's 3 or more consecutive pregnancy loss at, very important, 20 weeks or less, and the weight should be 500 gram or less. Etiology is parental chromosomal abnormalities, if there are any parental chromosomal abnormalities. Second is uterine causes. So what are the uterine causes? Like congenital malformations in the uterus, okay, can be a cause. Congenital malformation of uterus as well as cervical incompetence. Then the third is immunological factors. Then is autoimmune factor. Autoimmune factor, especially antiphospholipid syndrome, inherited thrombophilias, and maternal diseases such as diabetes. So etiology is parental chromosomal abnormality, uterine cause like congenital malformation and cervical incompetence, immunological factors, autoimmune factor like APLS syndrome, inherited thrombophilia, and maternal disease like diabetes. Now, what is the counseling method and investigations after recurrent abortions? So the counseling that should be done and the investigations after recurrent abortions are, first is the patient should be counseled and prescribed investigation after 2 abortions. Okay, after 2 abortions, since the pregnancy loss is high after 2 losses. So after 2 losses or 2 abortions, the pregnancy loss rate is going to be very high, and this must be counseled to the patient. A detailed history should be taken regarding the pregnancies that resulted in the miscarriage. Okay, so we need to take a detailed history of the obstetric history or the history of the pregnancies that resulted in miscarriage. Investigations depend on the gestation. So investigation, if you see, the investigation will be depending on the gestation at which the pregnancy losses occurred. So like whether 20 weeks or 14 weeks, what was the gestation period when the pregnancy loss occurred, and whether the fetuses are going to be viable or not. Then karyotyping of the partners. Karyotyping of the partners is going to be indicated because in cases of repeated early abortions, in any case of repeated early abortions, karyotyping of the partners must be done. Next is investigation for cervical incompetence and uterine malformations are going to be indicated if the history is suggestive. So very important, investigations for cervical incompetence and uterine malformations must be indicated if history is suggestive. And autoimmune disorders may be ruled out. Okay, all autoimmune disorders may be ruled out, and screening for diabetes is very important, and serological tests for syphilis also are indicated. Okay, very important investigation. So investigations, the gestation, okay, the karyotyping, then investigation for cervical competence and uterine malformation, investigation to rule out autoimmune disorder, to screening for diabetes, serological tests for syphilis, all these may be indicated. Now, what will you give the advice? What advice will you give regarding the future pregnancies in this kind of recurrent abortion patients? So, the advice is, on investigation, abnormalities to be corrected before planning of pregnancies. Okay, so if on investigations, the abnormalities to be all the abnormalities should be corrected, okay, or to be corrected before planning of pregnancies. And the women should be advised on report to the specialist as soon as pregnancy is going to be diagnosed. So we need to ask the women to report to the specialist as soon as the pregnancy is diagnosed, since they may require treatment in certain conditions such as antiphospholipid syndrome, diabetes, as well as so on. So we need to advise the mother to go to a specialist immediately after the pregnancy is diagnosed, especially in condition like APLS, diabetes and all. Then the women should receive antenatal care. The women should receive antenatal care in a high risk pregnancy clinic. Very important, in a high risk pregnancy clinic, and deliver in a center with all facilities for mother as well as newborn. Now moving on to the next type of abortion, very important, septic abortion. So what do you mean by septic abortion? Septic abortion usually results from a criminal intervention. Okay, septic abortion usually intervenes from a criminal intervention to terminate the pregnancy, and to a much lesser extent from legal abortions. So very important, usually legal abortions mostly it will not result in septic abortion, but illegal abortion, criminal abortion will be resulting in septic abortion. So the infection, if you see, it begins as endometritis. So the infection begins as a endometritis due to retained products of conception. So due to these retained products of conception, the infection will be beginning as a endometritis, and if not treated, if at all not treated, the infection may spread further into the myometrium as well as the parametrium. So if it is not from the endometrium, the infection will be spreading to myometrium and parametrium if not treated. And parametritis may progress into peritonitis. Very bad. Okay, parametritis can be progressing to peritonitis. It is one of the most common causes of morbidity and mortality, especially in developing countries. So very important, it's going to be severe. It will start as endometritis, and if at all not treated, it will go spread into myometrium and parametrium, causing parametritis, then which can progress into peritonitis, which is very worse. And that is why it's a very important cause for morbidity and mortality, septic abortions. Now let's look at the etiology for septic abortion. So first, it usually results from an unsafe or illegal abortion. That is the first etiology. Usually it is going to be polymicrobial. Okay, usually it is polymicrobial in origin, and the common pathogens are going to be gram positive and gram negative aerobes. Okay, gram positive and gram negative aerobes, as well as facultative or obligate anaerobes. It is because all kind of microorganism can be involved in this. It is polymicrobial. And very important, Clostridium perfringens. Clostridium perfringens is also reported to be one of the pathogen associated in particular with illegal abortion. According to WHO, okay, 68,000 women die each year. See the rate, it is 68,000 women die each year due to complications from unsafe abortions. Okay, complication from unsafe abortions with the sepsis as the main cause of death. So 68,000 women die each year due to complication from unsafe abortions with sepsis as the main cause of death. Now let's look at the clinical features. So clinical features, if you see, the patient presents with fever, chills, abdominal pain, vaginal discharge, vaginal bleeding, as well as history of recent pregnancy. Okay, fever, chills, abdominal pain, vaginal discharge, vaginal bleeding, and history of recent pregnancy. Now, what do you mean by septicemia? So, septicemia, all the signs and symptoms of septicemia will be there in this patient, like high fever and prostration, tachycardia, tachypnea, respiratory difficulty, low blood pressure, and there may be evidence of peritonitis. So high fever, prostration means very tiredness. Okay, tiredness or weariness. So high fever and prostration, tachycardia, tachypnea, respiratory difficulty, low blood pressure. There may be evidence of peritonitis also. Okay. Now let's move on to the investigations. So what are the investigations that you will perform? Routine blood and urine investigations. First is going to be a routine blood investigation. All the routine blood investigation as well as urine investigations should be done. Blood, urine, high vaginal swab and cervical culture should be taken. Okay, blood, urine, a high vaginal swab as well as cervical culture should be taken, and ultrasound examination would reveal the presence or absence of retained products of conception. So ultrasound will be revealing the presence or absence of retained products of conception. Now we are going to grade. Okay, we are going to grade septic abortion as grade 1, grade 2 and grade 3. So what are the features of grade 1 septic abortion and grade 2, grade 3? So grade 1 septic abortion, first, it is going to be limited to the uterine cavity. Okay, it is going to be limited to the uterine cavity. Second, the patient's general condition is going to be stable. And third is pyrexia can be there, offensive vaginal discharge can be there, and vaginal examination may show a partially opened or a closed cervix with a bulky tender uterus. Okay, there is going to be a bulky tender uterus and the fornices are going to be free. So what is grade 1? The grade 1 septic abortion features are: it is limited to uterine cavity, patient's general condition is stable, pyrexia and offensive vaginal discharge may be there. On vaginal examination, a partially open or closed cervix with a bulky tender uterus and the fornices are free. Now moving on to grade 2 septic abortion. First, the infection has spread beyond the uterus to the parametrium. So the infection has spread beyond the uterus to the parametrium and the patient is going to be more acutely ill. Okay, the patient is going to be more acutely ill. The lower abdomen is going to be slightly rigid and the tenderness is going to be present over the hypogastrium as well as on the other side. Vaginal examination reveals a tender adnexal region as well as diffuse fullness with tender and a bulky uterus. So in grade 2, the infection is going to be spread beyond the uterus to the parametrium and the patient is going to be more acutely ill. The lower abdomen is going to be slightly rigid and tenderness will be present over the hypogastrium on either side. So on vaginal examination, it reveals a tender adnexal region and diffuse fullness with a tender bulky uterus. Next is grade 3 septic abortion. The infection has spread beyond the pelvis. Okay, so here the infection has spread beyond the pelvis and the patient is going to be very ill with signs of peritonitis. Very important. Signs of peritonitis is going to be present in grade 3 septic abortion. So signs of peritonitis like fever, dry tongue, rapid pulse, distended and a tender abdomen, all are the features in grade 3. So grade 1, grade 2 and grade 3 is septic abortion and their features respectively. Next, how are you going to manage? So management of septic abortion is, first we are going to start with 2 large bore IV lines with normal saline or ringer lactate. So 2 large bore IV lines with normal saline or ringer lactate should be started and we need to start oxygen if required. Very important is a combination of ampicillin which is 2 to 3 gram IV every 6 hours. Ampicillin 2 to 3 grams intravenously every 6 hours. Okay, every 6 hours is going to be combined with aminoglycoside. Okay, aminoglycosides. These aminoglycosides, example say gentamicin, 2 mg per kg, loading dose followed by 1.5 mg per kg every 8 hours is going to be given. So aminoglycoside loading dose is 2 mg per kg, then followed by 1.5 mg per kg every 8 hours is going to be given as the initial regime. Okay, it's going to be given as the initial regime which is going to be subsequently changed according to culture reports. So initially ampicillin with aminoglycoside combination is given. Then blood and component transfusion if needed. X-ray of abdomen erect view, okay, is needed. And removing the focus of sepsis. We need to remove the focus of sepsis. If at all the retained products of conception Manual vacuum aspiration as well as dilatation and curettage can be done. If retained products of consumption, manual vacuum aspiration and or dilatation and curettage can be done. If perforation, if there is perforation of the bowel or rupture or perforation of the uterus is going to be suspected, then laparotomy under antibiotic cover is the best option. So if perforation of the bowel or rupture or perforation of the uterus is going to be suspected, rupture of or perforation of the uterus is going to be suspected, then laparotomy under antibiotic cover is the best option. Hysterectomy may be needed in some septic abortion patients. So management, start with IV lines, start oxygen, give a combination of ampicillin aminoglycoside, give a blood transfusion if required, X-ray abdomen erect view taken, removing the focus of sepsis. If retained products of consumption, MVA or DNC can be done. If perforation of bowel or rupture or perforation of the uterus is suspected, then laparotomy under antibiotic cover is the best option. Laparotomy under antibiotic cover is the best option. Hysterectomy may be needed in some septic abortion patients. Now, what are the differential diagnoses of septic abortion? So, the differential diagnosis of septic abortion are acute appendicitis, ectopic pregnancy, twisted ovarian tumor, acute pelvic inflammatory disease, shock due to non-obstetric conditions, long-term sequelae of septic abortion. Okay, what are the long-term sequelae of septic abortion? It's going to be chronic pelvic pain, chronic pelvic inflammatory disease, infertility due to tubal block. So the differential diagnosis of septic abortion are acute appendicitis, ectopic pregnancy, twisted ovarian tumors, acute pelvic inflammatory disease, shock due to other non-obstetric conditions, long-term sequelae of septic abortion. What are they? Chronic pelvic pain, chronic pelvic inflammatory disease, as well as inflammatory due to tubal block. So thank you. So we have come to the end of this PPT. We have covered abortion completely, okay, from the types, from the definition, their management. Okay, so if you like this video, please do like, subscribe and share this channel. And if you want to watch all the videos of mudaliar, menon, obstetrics as well as other subjects on final year MBBS topics, you can subscribe this channel. Thank you.